welcome to Street Drugs Discussions. This one is going to be hosted by me, not James Morgan, as you were promised, and I know that's probably a letdown for some of you, but I'll do my best to get through. So today's street drugs discussion is about drug-related death statistics, and today we're lucky to have Derek Winter, OBE, who was the senior coroner for Sunderland and also deputy chief coroner of England and Wales, and has a lot to tell us about the role of the coroner in assigning drug deaths. And also we have Dr. Caroline Copeland, who is senior lecturer in pharmacology and toxicology at King's College London. I believe, Caroline, you're at the Guy's campus. And you're also director of the National Programme on Substance Use Mortality. So without further ado, I will pass you on to Derek Winter, who's going to tell us about his roles in the coroner's office. So over to you, Derek. Thank you.
Thanks very much, and thank you for this invitation to explain the work of the coroner. So I'm going to try and put that role of the coroner into some context around the new death certification system that came into place in September last year. So we now have the medical certification of death by a doctor alongside a medical examiner, and we have the judicial certification of death by a coroner. So where does the division of labour actually lie? Well, the doctor, if they're dealing with a natural death, can give the cause of death to the best of their knowledge and belief. So they don't have to be sure about that natural cause of death. The safeguard to avoid repeat of Dr. Shipman was to have the death certificate issued by the doctor scrutinised by a medical examiner. So there would be an independent scrutiny of that natural death by a medical examiner who would look at the medical records. They would speak to the family to make sure that there were no concerns. And also they would make sure that the wording on the death certificate made sense, because what's on the death certificate, whether signed by a doctor or by the coroner, will feed into mortality statistics, and that will determine where expenditure is spent and what trends there might be, which is really important when considering drug-related deaths. So if the medical examiner is fine with everything that the doctors said, the death certificate will be issued. So not every death goes to the coroner. So the doctor's dealing with a natural death. So this is a naturally occurring disease process running its natural course. And the old rule of the doctor having to see the patient for within the last 28 days has gone. As long as they've had some meaningful engagement with their patient, they can sign the natural cause of death. So as you can imagine now with the medical examiner, if there's an issue, perhaps that Gran had taken too much tramadol, that can be sent to the coroner for investigation. So there is this clear division of labour, and cases which have to go to the coroner are set out in the notification of death regulations. And basically they are referred to the coroner because either the cause of death is not known or the cause of death is likely to be unnatural. And believe it or not, there is actually a cause of death list that the Royal College of Pathologists have published, and that's on their website. So the coroner, if a case is referred to the coroner under the notification of death regulations, and they specifically deal with drugs and toxic substances, will start to do an investigation. And the coroner has to decide whether they're going to pursue this investigation. So whether the duty to investigate is triggered is something that the coroner will be very careful to look at, because sometimes deaths will be referred to the coroner because there might be a worry about something or the cause of death is not known. So the coroner may carry out through their local pathologists a post-mortem examination, which does not necessarily mean an invasive examination where the body is examined externally, and then all of the organ systems are examined in turn. That's quite a traditional way of dealing with establishing the cause of death. Incidentally, a pathologist gets paid £96 to do that by the coroner. That's the statutory fee for an invasive examination. Sometimes that invasive examination will be accompanied by toxicology. So the pathologist will take samples of blood, urine, vitreous humus, or fluid from the eye, and the samples will be sent for analysis, looking for prescription drugs and drugs of misuse. And if the cause of death comes back as natural, the coroner is going to finish with the case there and then and issue the death certificate. So there's always going to be a slight time delay before the coroner decides whether or not the cause of death is going to lead them to hold an inquest. So it's really important that this post-mortem examination is carried out in a timely way. These days, it's not always done by an invasive technique. More and more coroner areas, my previous area is included in that, as is Leicester, Lancashire, will use CT scanning in appropriate cases. And that is usually funded by the local authority, who fund the local coroner service. It's not a national service, it's funded locally. So it's important that whether the post-mortem is by invasive means or by scanning, or is just possibly even just an external examination of the body linked to toxicology, that a very clear cause of death is established, because coroners sit on a rich seam of information around the cause of death, and in particular toxicology. And the pathologist will eventually give a formal cause of death and a post-mortem examination report. Now, that can take weeks, it can take months. Sadly, in paediatric cases, it can take up to a year, because we have a shortage of paediatric pathologists. So the coroner is very interested to know what the cause of death is. And very recently, the Royal College of Pathologists have issued some supplemental guidance to their autopsy guidance to say to pathologists that if they give the cause of death, for example, as mixed drug toxicity, they should, as a matter of good practice, then say what those drugs were, because that cause of death, mixed drug toxicity, will feature on the death certificate that the coroner, in their judicial role, will eventually issue. And of course, a drug death is an unnatural death. So there will then have to be an inquest. And it's really important to understand this pathway, how the coroner doesn't see all deaths, how the coroner can see some deaths but discontinue the investigation, or in cases of unnatural death, including drug deaths, there will have to be an inquest. So there are these constant processes that the coroner is undertaking, which are essentially a triage. What is going to go through to an inquest hearing? And an inquest hearing can take a lot of time to arrange, depending upon the availability of the post-mortem report, the availability of the toxicology report. Lots of toxicology providers are in the private sector now. There aren't many NHS providers. Some coroners, with their funding local authorities, will send toxicology to procurement, which builds in another potential delay. But ultimately, it's the coroner's shout as to what is to happen with post-mortem examination and toxicology. And cost is just one factor. So it's not the sole driving factor. Now, the big problem with getting good, meaningful, real-time statistics was that the coroner would not be able to issue the final death certificate until after the inquest. And if that's going to have to wait for this process to take place, from post-mortem report, toxicology report, witness statements, fixing a hearing, calling witnesses, that will take weeks, months, potentially up to a year. So there would be a lag in meaningful data being available into the system, because at the end of the inquest, lots of coroners would report to Caroline on a standard form their findings, including the toxicology report. Now, that's too long to wait. And With Caroline's initiative and with the Chief Coroner's Office and with some input from myself and under the guise of the Department of Health also, there is a system in place where coroners can give permission to their toxicology provider to give the toxicology report findings straight to Caroline. It's a completely anonymised process, so there's no breach of GDPR information, and most coroners, bar a few, have signed up to this arrangement and have told their toxicology provider to tell Caroline straight away what's going on in the toxicology world so that they're not waiting for the inquest to be concluded. Now, the inquest itself is a public hearing and it's an inquisitorial process. The coroner leads that process. It's not adversarial, so it's not a case that somebody's putting a case. It's the coroner's inquiry. It's a fact-finding function. The coroner has to decide who was the person who's died, when did they die, where did they die, and how did their death come about. And the coroner has to record a conclusion. People still fall into old language of calling it the verdict. It's not a verdict, it's called conclusions. We're trying to move away from the old criminal implicated coroner system with softer language. It's a conclusion. And the coroner's decisions are made on the balance of probabilities. That is, something is more likely than not. And as you can imagine, there is a lot of information coming into the coroner. The people who participate in the inquest process are called interested persons. They're not parties because it's not a trial. No one's on trial. And the coroner will call evidence which is relevant to the function that the coroner has, and no more. The coroner can't get into blaming or fault finding. So the coroner will have that hearing. The family will participate. They may have a view about the evidence. There may be a dispute about the cause of death. The family will hold a lot of information about their loved one, and coroners very often will receive something of a pen portrait about the deceased to understand something about their lives. And it's a much more personalised process. The families are supported with the coroner's court support service volunteers who have specific training in bereavement. So they're used to dealing with people in that stressful situation and worrying about coming to coroner's court. Now, at the end of the hearing, the coroner has to provide a conclusion. That used to be called the verdict, and as I've said, we move away from that, and there are a number of conclusions, some of which are called short form conclusions, and you may have heard about those. So the coroner can sometimes find there's been an accident, a misadventure. Natural causes is still a conclusion available to the coroner. If, having heard all of the evidence, the coroner finds it was still a naturally occurring disease and nothing else was implicated. In 2013, when the Coroners and Justice Act, which gave us a lot of reforms, including a chief coroner, came into effect, there was a new short form conclusion created called drug-related. And that's a very helpful conclusion to be available to the coroner, because there are other short form conclusions that may fit the bill. So if somebody were to take an accidental overdose of their prescribed medication, would that be a drug-related conclusion on the balance of probabilities? Or might it be said to be an accident or some sort of misadventure in the sense that the death was the unintended consequence? It's important that coroners get this information right, because if somebody takes drugs, whether prescription or illicit, to end their own life with the intention of doing that, then that's going to be a suicide. It won't be categorised as a drug-related death. So it's really important that coroners listen to the evidence and then arrive at a conclusion appropriate to that evidence. So if a driver of a vehicle under the influence of drugs were to crash their car and die, there's also a short form conclusion called road traffic collision. So the conclusion doesn't always tell the sequence of events leading to the death. So that's the importance of having access to good toxicology data, because the conclusion is just one part, it's the concluding part of the coroner's inquiry. But drug-related deaths conclusions are really important because, again, government will do number crunching around statistical data to see how many drug-related deaths there have been. They will look at suicide data. And whilst I've got a captive audience, remember never to say people commit suicide, they die by suicide. Suicide was decriminalised in the 1960s. So careful language. Coroners, we've done a lot of work with coroners around careful use of language. Now, at the end of the inquest, the coroner completes what's called a record of inquest and will sign a form to tell the registrars of deaths that they can now issue the death certificate. So that's a really important process to understand. And on the back of the coroner's public health functions is something which is also very important, because sometimes arising from an inquest, coroners have concerns about the sequence of events leading to death. And although the press say coroners have made recommendations, coroners don't make recommendations. Coroners can write a report to a person, an organisation, who can change things for the better, because most families, in my experience, come to coroner's court and say they don't want this to happen to somebody else. So the coroner can write a prevent future death report and say, send it to a pharmaceutical company to say that their information leaflet is causing them concern, or this is the third such death that the coroner's had to deal with. And the person who gets that prevent future death report has to respond within 56 days to tell the coroner what they're going to do about that report. And just for your information, and you can have access to these links after this webinar, all reports and all replies are collated by the chief coroner. And there is now a searchable database of all of those prevent future death reports and responses on the chief coroner's website. And you can read all of the relevant reports you want to have access to around drug-related deaths, around a particular drug, if that were searchable from within the report. And also, one of Caroline's colleagues, Dr. Georgia Richards, has a great website with a preventable tracker on it. And that does a deeper analysis of what coroners have been doing. And you can do a much deeper search than the chief coroner's website to look at perhaps individual coroner areas, look at particular drugs, and to see how many PFD reports a particular coroner has written and in what area. So there's lots of information about your own coroner area that's available. While I remember every year a coroner must do a report to the Ministry of Justice. This is the government department who have responsibility for coroners. And if you want to search the Ministry of Justice website, look at coroner statistics 2024, and they get published in the following May, so May 2025. So coroners do a calendar year report, and that annual report is then put together by the Ministry of Justice to say how many deaths were referred to the coroner, how many deaths led to an inquest, how many post-mortem reports, post-mortem examinations the coroner did, whether they involved histology, toxicology, how many were done by scan. And there's a really useful data there. And the statisticians in the chief coroners, in the MOJ, will provide a narrative around all of that information. And that's really very helpful. But again, if you want to look at some more information around what's happening in your area, in perhaps the coroner area that you work in, or a number of coroner areas that you work in. If you go into the MOJ statistics, there is a link to what's called the data visualization tool. And in that data visualization tool, there's a drop down box which does an analysis of each individual coroner area. So you could search for Leicester, and it will tell you how many deaths there were in Leicester, how many post-mortem examinations were there, how many were by scan, how many were invasive, how many involved histology and toxicology. It won't produce the reports, but it will give you an idea as to what's going on there. It will also tell you the timeliness of the coroner area. On average, how long does it take to get to an inquest? So in the 2024 data, the inquest range amongst the coroner areas in England and Wales average from 10 weeks to 76 weeks, which is a huge disparity, usually accounted for by how well a coroner area might be resourced by their local authority, or there might be other reasons for such delay. The law actually says coroners should usually try and get their inquest done within 6 months. And lots of coroners work very hard to achieve that, but there may be factors out of their control. They may be waiting for the outcome of a criminal trial before they can finish their inquest, or they may be waiting for a decision from the CPS, the Crown Prosecution Service. So lots of factors build into delay. But the data is there, and as I've said, coroners sit on this rich seam of information. It sits with the MOJ, it sits with Dr. Richards, it sits with Caroline, who you'll hear from, and you can see how all of that information can better inform what's going on generally in our community. And to give you some idea as to the extent of death investigation generally, in England and Wales in 2024, there were 568,000 registered deaths. 175,000 or thereabouts went to the coroner. There were 39,600 inquests, and there were 81,200 post-mortem examinations. And the average waiting time to an inquest was said to be 31 weeks. So the point that I want you to understand is that there is this funneling process when a death is referred to the doctor and the medical examiner or to the coroner, and we each have our distinctive roles. But ultimately, if there's an inquest, there will be a conclusion. There may be a prevent future death report, and coroners will do their best to cooperate with the gathering of important statistical information, because I've always maintained that coroners, as well as their judicial function to help families understand what's happened, they have a public health function, and this is just one part of that function. So if I've missed out something, I'm sorry. I'll have a check through some of my notes to pick up after Caroline has done her bit, which is probably more interesting than my bit. But that's enough from me for the moment. Thank you.
Thank you very much, Derek. That's really informative, and what a lot of work goes into making those decisions. Yeah, I think a lot of us would be really surprised at how detailed and how much information you have to process to come to those conclusions. Before we take any questions, we're going to have our next speaker, which is Dr. Caroline Copeland. So I'll pass you over to Caroline, and then we'll have the question round. Over to you, Caroline.
Great, thank you. So I'm going to be talking about some of the recent research conducted in my group, looking at how the language used by coroners has impacted upon the ability of ONS to correctly assign the drugs involved in deaths and what the implications might be for policy and treatment as a result. So I'm just going to share my screen. Okay, let me know when you can see that.
Yep, we've got it.
Grand. Okay, fantastic, grand. So yeah, so as I just said, that's this is some recent work that I'm going to be talking about that we've done. So the Office for National Statistics, or the ONS, gets reported every death, well, every birth, every death, every marriage that happened in this country, but we're concerned about deaths today. And so they get all either death certificates or records of inquest from the coroners regarding these deaths reported to them. And they look at the cause of death fields on these certificates to see, you know, how they can code and assign deaths to their various causations. And so this is what a standard sort of record of inquest from a coroner can look like. And the medical causes of death are written out as 1A, 1B, 1C, and 2. So cause 1s are things that have directly led to the death occurring, and cause 2s are things that, because they're there, have contributed to the death, but on their own won't have caused the death itself. So contributory to the cause, but on their own not sufficient for cause. And then the C, the B, and the A is not every death has all of these listed, but in general, when there are multiple cause 1s, it's that A is caused by C, A is caused by B, is caused by C. So you might have something like brain hypoxia, so where there's no oxygen that's been got to the brain, and you might have a 1B of cardiac arrest. And if the blood's not circulating around the body, then it's not going to be delivering oxygen to the brain. And you then might have a 1C of something like cocaine use. So the cocaine use has caused the heart attack, which has then caused the hypoxia. So that's how it might work. And you might have a cause 2 of something like, in this example, atherosclerosis, so fatty deposits of cholesterol in the arteries and veins, which would be a cardiac stressor. So when you add in the cocaine to that, the fact that you've got compromised cardiovasculature, that will have contributed to the cocaine toxicity. Now, if a coroner, as Derek was just saying, cites the actual name of the drug, ONS is able, with their text detection software that they have, to be able to say, grant, this death is due to use of morphine or whichever other named drug there might be. But if something more ambiguous is used, such as mixed drug toxicity, or even opiate or opioid toxicity, that's ambiguous enough for ONS to not be able to know which drugs were actually involved. So mixed drug toxicity, something like a paracetamol codeine overdose of cocodamol, which is available over the counter, could be regarded as a mixed drug toxicity death, but so could a cocaine and heroin overdose as well. And those two types of deaths are very different in the type of person, the circumstances surrounding them, the context of them, and so on and so forth. So it's really important to be able to understand which drugs are actually involved. And what we sought to do is to use the database that we've run to try and work out how many deaths might ONS be not able to assign the drug type to because of this limitation, because of the use of ambiguous causes. So ONS can't count those. So the MP-SUM, which is the database that I run, is voluntarily reported to by coroners. And I think we've got almost all, still not all of them, Derek, unfortunately. Still got some holdouts in London and in the East Midlands. But anyway, over 90% at this point. And in addition to the record of inquests, we also get reported the full toxicology reports. And that's what's really important here, because in the toxicology reports, we can see every drug that was detected at post-mortem, but also you get an interpretation from the toxicologist saying, oh, XYZ PQR were the drugs that were detected, but actually only XYZ were important in the death happening. And the others are incidental post-mortem findings. So you might have something like a low dose of an antibiotic or aspirin that is detected, that the coroner has said, oh, the toxicologist said, yes, it was there, but actually it was the heroin and the morphine and the cocaine which were the important things here. So when we get a report sent to us that has these ambiguous cause terms, we can look at that toxicologist's interpretation and see where opioids, for example, were detected and then implicated in causing death. So where the opioid detection was deemed important by the toxicologist. So that means that the cases on the NP sum that are made up of attributable to tramadol or methadone use is made up of cases where the drug has been implicated specifically by name, but also with cases where there were these ambiguous causes given, but we've been able to use the tox reports to work out the drugs that were implicated. So to give you a worked example of this, so say on the NP sum we had 100 deaths where tramadol was implicated in having caused death. And in 60 of these cases, it was specifically named on the death certificate. But in 40 of them, it was one of those ambiguous causes that was given. We can then extrapolate using the ONS data to say, well, ONS gets reported every death. So as I said, we don't get every single one to the NP sum. But we can say, well, if this is only representative of 60% of deaths, how many have ONS missed being attributed the drug that was used? So that would be another 40%, so that would be 120 that they hadn't been able to count. And so the estimated true number would be closer to 300 deaths, which is really quite different in terms of the number and the proportion of deaths that might have been missed. So this is just an example. These aren't real numbers. And we'll come to look at some real numbers in a second. And to just sort of front load sort of the importance of counting the number of deaths due to specific substances. Tramadol is a prescription opioid, and it was noted in the early 2010s that there was a rising number of deaths happening due to tramadol use that were being reported to ONS. And in 2013, it was decided that we need to review the scheduling of tramadol. So drugs are classed under the Misuse of Drugs Act as Class A, Class B, Class C, and that determines the punishment that somebody is going to get if they're found guilty of supply, manufacture and possession. The scheduling of medicinal drugs is a number that's given to these substances. And depending upon the schedule that they're in, it's how tightly controlled the access to that drug is for medical use. So Schedule 1 substances are those that are deemed to have no medical use, so things like LSD or psilocybin, although they might move in the not too distant future. They are being trialled for psychedelic assisted therapy for people with depression. But anyway, they don't have a license at the moment, so they're in Schedule 1. And then you've got 2, 3, 4, 5, and then the ones that are in 5 are things that you can buy on the shelves in supermarkets. So your paracetamol, your ibuprofen, there's very little control. But then the 4, the 3, the 2, are generally prescription drugs, and drugs that you can get prescribed at a Schedule 4, you can get on repeat prescription, get several months in a row, whereas those in 3 are tighter controls, so you can't get as many in month's prescription as you would in a row, and you have to go and actually see the GP to be able to get them prescribed again. You can't just sort of tap on your app to say, send me more. And then the Schedule 2 substances are those that need safe custody requirements. They might need to be locked in a box and things like that. So tramadol was Schedule 4, so easy to get on a repeat prescription, didn't have to see a GP. And so in 2013, they were like, this ain't good, this trend with the number of deaths. So in 2014, tramadol was made a Schedule 3 substance. So this meant that if people wanted the repeat, they had to go and see the GP, justify why they had it. And this therefore obviously reduced the number of prescriptions that were in the community. And we can see that whilst there's not necessarily a huge reduction in deaths, there's certainly, you know, this upward trajectory does get blunted. And sort of the deaths have continued around about 200 a year since then. But the query is that if the number of deaths due to tramadol had actually been known correctly and had been counted appropriately, would this schedule change have been instigated sooner? And would we have had this blunting sooner and maybe been able to prevent some of these deaths from happening? So let's have a look at the numbers. So yes, so we're trying to estimate estimate the number of deaths due to individual opioids by triangulating the data between the ONS and the NP sum. So we use the ONS data, and the ones that we used is this one here, which is deaths related to specific substances. And then we extracted the same substances from the NP sum and did the analysis. So what does it look like? So here is sort of the overall over that 10-year period, how many deaths had ONS counted and how many might have actually happened. So for heroin and morphine over that time frame, there were 13,471 deaths reported to ONS where heroin and morphine had been specifically named. Triangulating with the NP sum, though, we've estimated that they're missing around about another 7,000 deaths, which, you know, is a huge underestimate, nearly a third. And so, you know, if you're drug treatment services and you're, you know, commissioned and funded and you're designing your interventions for a particular population, if you're suddenly told now you have to cater for a third more people, that's a huge difference in the type of thing that you might be able to offer and the type of design and implementation of what you're able to offer. So that's a rather large underestimate, and we observed that a similar underestimate throughout all of the opioids that we looked at. The highest underestimate was that for methadone deaths at 39%, and the lowest fentanyl deaths for 32%, but still between sort of a third, 40% of opioid deaths due to specific opioids had not been counted. So we then looked at these deaths and we looked at the underestimate that was happening year on year. So if we just have a look at the heroin one to begin with, instead of doing the overall numbers over this decade, which is what we've got here, we've then done a year on year. So in 2011, we've got how many deaths ONS were had captured and therefore how many were missed. So they got 70% of deaths in 2011, but that had dropped to sort of 65% of deaths in 2022. And over time, the underestimate is increasing. They're counting fewer deaths, and that is the case for all of the opioids except codeine, which had they were getting slightly better at counting codeine deaths. So codeine is slightly different from these other opioids because you can get codeine over the counter as a cocodamol preparation. So there were slightly different conditions for this substance, but all of these ones, the underestimate was increasing over time. And what we've plotted in orange is the median number of drugs detected at post-mortem in cases reported to the NP sum over this time period as well. And what this orange line is showing in all cases is that the number of drugs detected in these cases has increased. So from 4 on average substances in the early period to 6 or 7 substances by 2022. So that's the number of drugs that people have taken together. And so what we have hypothesized is that this increasing polypharmacy, so increasing number of drugs co-administered together over time, has led coroners to not write that a drug is attributable to a particular substance, but rather a shorter form, which would be something like mixed drug toxicity or polysubstance use. And so we think that this polydrug use trend is contributing to the use of these more ambiguous cause terms, and there's a high level of correlation between increasing polydrug use and decreasing numbers captured by ONS for all of the opioids that we looked at, including codeine. You might be wondering why oxycodone isn't featured here, and that's actually because there are very few deaths attributable to oxycodone in the UK in comparison to the US, and the ONS doesn't actually provide a number of deaths due to oxycodone, so we couldn't do that comparison here. Okay, so to summarise, deaths due to specific opioids are being underestimated by ONS, and over time that underestimation is getting worse at the same time as the number of post-mortem drugs is increasing. So what impact does this have? So we think that a lot of it is due to increasing rates of polysubstance use, which in itself can be difficult for toxicologists and pathologists to maybe be able to attribute death just to a single substance, but rather the group of substances due to the additive effects. And so we've probably got an underestimate. Well, we know that we almost definitely have an underestimation of opioid-related mortality, which will have an impact upon the resource allocation for the for addressing opioid-related deaths. And in fact, if you actually look at the most recent ONS report that was produced in, I think it was September it came out, or was it October? Time is flying so quickly, I can't remember. You'll actually see there's a lot of caveats in that report now about the number of deaths due to specific substances, because I should point out that this work wasn't just done by us, it was actually done in collaboration with ONS, because they themselves were concerned at the number of deaths that they were missing, and this was their sort of way of saying, look, we know that we're missing these deaths, it is a problem, and they're not sort of hiding away from this problem, they're trying to highlight it themselves as well. But yes, you'll see all those caveats in that report. Grand. So that's all from me. I'm happy to take some questions now.
Thank you very much, Caroline. That was very informative. Just a quick question. When you're looking at the multi-drug toxicity, do any certain combinations come to the fore more than others?
Well, polysedative use, very, very common. So heroin along with, particularly heroin along with benzodiazepines is very common, but heroin and cocaine as well, increasingly common. Unfortunately, it's not possible at post-mortem to determine whether someone might have consumed crack cocaine or powder cocaine, because cocaine toxicology looks like cocaine, like it's a drug that has a structure. We can't tell how it was administered, unfortunately, but those are the major ones. And of course we're seeing emerging, particularly pre-gabalin, of the gabapentinoids as well. So there are most common repeat offenders in terms of polypharmacy for sure.
Well, thank you very much. Well, we have some questions that have been put forward. So I'll start from the beginning. Again, this is for Derek. What policy, contract, resource, or otherwise changes would you want to see to improve the timeliness and increase clear findings of coroner outcomes? So what do you need?
The big thing coroners can do is to talk with their funding local authorities, because ultimately they have to fund the service. Coroner teams are made up of usually a senior coroner, an area coroner, full-time judges. There are a group of assistant coroners who can support the work of the full-time staff. But coroners' officers are our eyes and ears, and they are primarily now employed by the local authority. Some police forces still provide them. But it will come down to resources and the importance of the data collection, because if coroners are trying to reduce the backlog of their inquest load, they're probably not able to get out and about to talk to the local authority or to drug teams or suicide teams or their faith groups in their community. So the more time that can be freed up for the coroner to do that is a good thing. And I did look at some of the other questions that came in. It's not just about those resources, but I as a coroner in practice, would always engage with as many people as I could to get the word of the coroner, the work of the coroner out there so that people understood. And that included the local authority and all of those within the local authority who might have an interest in the work of the coroner. That was another question around engagement. My practice, and I know that of some other coroners, is to allow the suicide prevention group within the local authority, or the drug and alcohol teams within the local authority, to come and have access to my data. Everything now in the world of the coroner is on a computer system. There are two main providers, Civica and WPC, and we can give a lot more help to local drug prevention, suicide prevention teams than sometimes they assume we can't give to them. Some coroners are more engaging about it than others, but I made it my aim to allow access at least once a year under supervision by one of my coroner's officers to help the drug teams, for example, had a standard template they wanted to fill in with information, and they could extract that. So simple things, postcodes, people's occupations. Sometimes the suicide teams would be interested in whether somebody was a veteran. So coroners can do all of those things. It's not just their inclination, no. It's how well resourced they are to give up their own time and to allocate a coroner's officer to make sure that the data is collected properly. And of course, I would get people to sign confidentiality undertakings. If they belong to a professional group, I would at least have the sanction of reporting them to their professional organisation if they were to breach the terms of my engagement, because that's always the difficulty. I wouldn't seek family consent because it's to do with the bereaved, to do with the deceased. So there are things coroners can do. I'm not saying every coroner will do it, but for those who would like to have better coroner engagement, contact your coroner's office and say, here you are, this is what you do. Can you do some things together? You don't have to be best friends around it, but you can be professional. And some coroners may not know you exist. They should, because we do training. Caroline came to talk to all the coroners a year or so ago to explain her work. So there are things you can do. Don't be frightened. If the coroner says no, well, they say no, but you might just get the foot in the door.
Thank you, Derek. Is there anything you'd like to add there, Caroline?
No, nothing further to what Derek has said. Thank you.
Okay, thank you. Well, we got Richard Jones has asked a question, but he's told us that had been answered in Derek's comprehensive account of the coroner's work. There's another one for Derek, and this is a kind of a little bit about the attitudes. I'll read it out to you so you can hear it. We are aware of many people who sadly died from a heroin or other drugs, were ambivalent about their death. For example, after taking a dose of heroin, the individual is not bothered whether they wake up or not after their hit. The cause of death is somewhere between misadventure and suicide, with root cause of hopelessness. How can coroners make better account of these tragic cases that have often been let down by the system?
They are incredibly difficult cases, and that's why the evidence is really important to gather, and not just to make assumptions about people's lifestyles. Very often, they may not trust organisations to help them. They may be embarrassed. Sometimes it's a secret addiction. It's a fine line between whether it's an accident or misadventure. The statisticians put accident and misadventure together, believe it or not, but that's for them. For suicide, a coroner would have to be satisfied now on the balance of probabilities that somebody was responsible for their own death and intended to die. And establishing intention is difficult. Until the law changed after a Supreme Court case of Morn, the legal test for suicide was beyond reasonable doubt, the old criminal standard of proof. So coroners had to be sure of people's intention. Now it's on the balance of probabilities. And the effect of that is it's a less stringent bar to get over. So you will see in statistics to come, I would imagine, that there being a lower bar, there will be more suicides recorded, and therefore more mental health service input should follow from that, because having such a high bar disguised so many suicides. Coroners would be forced sometimes to record an open conclusion or to give a narrative conclusion, such as Derek Winter killed himself, but his intention could not be ascertained. So coroners will look at the evidence. They will look at service provision as well, and the efforts that were made by those who could help the deceased to continue to help them, because I know from my experience that people would disengage and then all of a sudden engage and disengage, or they'd move around, they'd have a very nomadic lifestyle. But coroners can look into that evidence, and very often you will find that somebody's worker may be called to give evidence, to explain to the family what had been happening. If the coroner thought, well, policy was not that effective, or there was a lot of turnover in staff, senior managers may well be called, or even the chief executive of an organisation, to explain what they were doing. And if the coroner thought there were concerns, then that can trigger the Prevent Future Death report. The coroner doesn't have a discretion when they write these PFD reports. It's mandatory. If they have a concern, they must do something. So the difficulty is sometimes you may not get a reply, and there's no power of enforcement to make people reply, although the chief coroner will be naming and shaming those organisations who don't reply. But ultimately, you may get a very good reply, and change may come about. And it's not a sanction, but it is, again, part of the public health function. And the other thing, from an organisational point of view, if they have genuinely let down somebody who was dependent upon their services, the only critique, let's say, a coroner could make is to make a finding of neglect. If there had been a gross failure to provide basic treatment, not complex treatment, which requires every twist and turn of complex judgments, but if somebody had been denied some basic treatment and need, a finding of neglect can be made. It's not a civil finding that leads to any sort of liability, but sometimes coroners have to go down that path. But it's a gross failure to provide something basic. So coroners do take all of these responsibilities very seriously. It's not just another drug death passing through. Depending upon the nature of an investigation, I would call for statements. I would call for people's records. I would ask the family if they had any concerns, if there were family around, and I would decide what evidence I was going to call. I wouldn't just leave it as, oh well, it's a drug death. They were ambivalent about whether they lived or died. Coroners can make a difference.
Thank you. I think actually the next question follows on a little bit from that, from another anonymous attendee, or maybe the same one, about the responsibilities of the coroner for highlighting the role that drug users, stigma against drug users has in attitudes towards, but also accessing services.
It is, and coroners want to know what's going on when there's a death, whether it's in their area or not. Sometimes people will, ask to one coroner area to see their friends take an overdose, possibly. You just don't know. But until you start asking the questions, and that's the good thing about the inquisitorial process. It is just that. It's an inquiry. What's been going on here? In certain circumstances, if Article 2, the right to life, is engaged, the coroner can extend the scope of the inquiry to look at in what broad circumstances the death came about. So particularly in prisons where people are in state detention, the state have an enhanced responsibility to look after people in their care. So it again, depending upon the nature of the death, the circumstances, coroners can require further information. And something I forgot to mention, not all cases are heard by a coroner sitting alone. In some cases, coroners will sit with a jury of between 7 and 11 jurors. So we don't even follow the Crown Court, who have 12. But if you're between 18 and 75, you could be summoned to a coroner's jury inquest. So there's a lot out of that, lot there, and coroners want to be kind, compassionate, and to do their public duty.
Okay, thank you. And I think another one for you, really, is about engagement with local authorities. It took me a little while to work out what LA was. Drug and alcohol related deaths, governance processes. How can things be improved and communication improved and a more timeliness in the response? Because you've mentioned that it can take quite a long time, and the work that you do with Caroline speeds things up a bit, but
it can take a while. But for example, my coroner officer team would know where within the local authority or the mental health trust to go to find out, and we would make specific inquiries. Was this person known to you? If they were known to you, what were you doing to help them? Send us your records. And coroners have lots of powers, but by engagement, you don't have to exercise those powers. But if a coroner had a troublesome person who was not cooperating, or an organisation, a coroner can issue what's called a Schedule 5 notice to make them deliver what the coroner has asked for, whether that's records or a statement. And failure to comply carries sanctions. And that's the last thing organisations want to do. So cooperation is key, and getting to know your coroner, and invite your coroner to speak to a group, get to know one another, what they think, educate them about what's going on, what the policies are, what the service provision is, what the strains are on the system locally. The coroner will be interested. It's not just about the courtroom. Coroners do a lot of work, in my experience, in the back office, engaging with lots of different groups, organ donation, a vast array of organisations who we have to liaise with. And, it's a two-way street.
thank you for that. I think we have one now for Caroline, which was about her data and the form that you showed, which is Richard comes from Richard Jones, says, I'm starting to see 1D on the certificates that you showed. Is this new or local particularity?
Probably a better question for Derek to answer than me, but we have started seeing Ds and even Es in some people that have given. So where it's been determined that there's been an even longer chain of events that have happened, but we don't see them very commonly. Most people just stick to the 1 to C. I don't know if you want to add to that, Derek. No, I could call you Graham. I'm so sorry.
Since September last year, when all the rules on death certification changed, they've included a 1D on the statutory form. It doesn't mean that the doctor has to put a 1D or even a 1C or a 1B. A 1A sometimes just tells the story. But Caroline was right in her presentation that it's 1A due to 1B, due to 1C, and now due to 1D. And that brings us in line with our national obligations. That's the reason it was put there. And the new medical certificate of the cause of death includes lots of other information like ethnicity and implantable devices, things that were not included previously. So yes, your question was right. There is a 1D.
Right, thank you for that. And what about the data that you presented, Karen? Was it pre-nitazines?
It was indeed pre-nitazines, and in anticipation of one of the questions, whilst Derek was answering that question, I've just been trying to code the deaths that we've received from 2024 from jurisdictions, because in the ONS report that was released this year, it was of 2024 registrations, which was majority 2023 deaths, but not quite. I've literally just finished coding them, but I haven't done the triangulation maths. It will take me about 30 seconds to do. So is there another question that
Okay, we
Derek can
well,
answer, and then I'll be able to tell you?
right, there's another one for you, Karen, but we'll come back to that one. So James Ellison's asked, well, makes a statement and a question. I successfully persuaded a coroner to remove methadone from a cause of death in a patient who had safely used prescribed high dose methadone for months and died the day he took a lot of crack cocaine. The observation is that toxicologists often implement methadone as causative in death because the therapeutic levels overlap with those seen in overdose. This doesn't seem to take into account the real life context of the patient. What can be done about that?
I have a short view on this. People can die with something, but not because of it. So coroners will look at causation, and that's potentially why the methadone was taken off that cause of death. Did it cause the death, or did it contribute to some part? But the fact is, they had it in their system, so it would be recorded in the toxicology report, but it may not have led to the eventual death. So again, you can have something, you may not die of it.
No. So maybe just a contributing factor, but
Potentially,
not the main.
But if there's doubt, I would call my toxicologist to explain it, or the pathologist, or the pathologist.
Okay, thank you very much, Caroline. Are you ready with your information?
Yes.
Hey,
Sort of. So, just as a bit of a caveat from this, I have only literally just coded them now, so this could not be hotter off the press in terms of the data. Or don't crash on me now. Oh, okay, hang on. I can do it another way. Sorry, is there another question for Derek? I need one more minute.
yeah,
There was a question about whether coroners come together regionally and nationally, and the answer to that is yes, they do. Coroners are subject to mandatory training for 2 days residential every year. We have a chief coroners conference where Caroline came to speak to all the senior and area coroners once a year. We have guidance from the chief coroner published whenever there are changes like death certification, guidance. That's all on the chief coroner's website. And recently the chief coroner has published what people view as a bench book. So this is publicly available. It's how coroners should approach certain types of case. Coroners will discuss best practice in syndicate groups. They may have a local coroner society. They may have individual. We have a medical legal committee. So there are lots of things going on in the world of the coroner to try and promote not just good practice, but consistent practice, because that was a criticism before the law was changed in 2013. Having a chief coroner provides leadership and guidance because we have so many regional variations, because every coroner area is funded differently by different local authorities.
I think what follows on from that point maybe is there a need to have standardized national guidance about recording polydrug use?
Coroners will adopt the cause of death given by the pathologist because they're our expert. And the latest supplemental guidance from our CPATH was to break down that cause of death if it's mixed drug toxicity, to actually name the drugs. And coroners are forever playing catch up with synthetic developments and goalposts that are moving with fentanyl and all sorts of scourges which are out there. And we rely upon the advice that we're given by our toxicology providers, our pathologists. Remember, coroners are now primarily lawyers. Doctors can't be coroners any longer unless they hold a legal qualification. But it's important to get the word out there. So we have people come to training to educate all coroners at all levels. Again, that was the importance of Caroline coming to do her bit, to explain the work that she's doing. We can't be aware of everything that's going on. That's the other thing.
Yeah, well, I think we're always playing catch up, aren't we, on what's happening out there. Similarly, are you allowed to send toxicology reports to public health teams before the death goes to inquest?
Coroners will have different views. Um, I would tend not necessarily to make them available in their fullest form, because remember, a cause of death can change. You know, a previous questioner had successfully persuaded the coroner to take out methadone. Well, you know, until the inquest heard, the death certificate won't be issued with confirmation of what the cause of death is or confirmation of what the drug toxicity may have been. But for my part, I protect the integrity of my inquest by having a coroner's officer help the drug team, the suicide team, with information which is not going to prejudice or compromise the inquest hearing.
Okay, thank you. Thank you very much. Caroline, are we ready now?
I'm ready. Yes.
Yeah.
So, for some reason, one of my scripts isn't working, but this is going to be a quite accurate, or if not wholly accurate. So, from 2024, so these aren't deaths that happened in 2024. These are deaths that were reported to the NP-SUM in 2024. And that's how ONS works as well. So they record deaths according to the year they're reported. And it takes anywhere from 7 to sort of 12 months for a death to be concluded at inquest. So that's how we end up with, you know, a 2025 report being of 2024 registered deaths, and that they come from a mix, most of 2023 and 2024 deaths. So we had 185 deaths reported to us with detections of nitazines. Now, the bit of script that isn't working is that if the nitazine detected was deemed causative in the death or not. But from memory, only about 11 deaths in total where a nitazine was detected, it wasn't implicated. So we can, maybe it might be 180 of those were implicated, but probably close to 185 anyway. And I've just gone through and I've coded where the nitazine was named, or if even if the specific nitazine wasn't named, if the word nitazine was used. And I'm giving ONS the benefit of the doubt, because nitazine has been misspelt by the coroners, sorry Derek, on quite a few of these, with 2 I's instead of 2 E's, or nitrazine I've also just seen on here as well. But if ONS was able to cope and count all of those, ONS would have counted 104 of those 185 as due to nitazines. So that's 56%. So if we do that extrapolation up, we would expect the total number of deaths from ONS. So ONS received 195 deaths, which happened, which were reported, I should say, sorry, in the 2024. So if we take that 195 as being 56% of the nitazine deaths, we're looking at a total number of deaths being actually 347. So 162 would have been missed.
Well, thank you. Thank you. And good to see that James is with us, and he spells it wrong as well every now and again. On the subject of toxicology, I'm going to try and pronounce this. Are orhine substances?
Orphines,
Yeah, that's
yes. So we are aware that orphines are on the horizon, and they are being looked for. We haven't had any deaths reported to us yet, but we're reported to at close of inquest, and so we expect any deaths which might have happened due to orphine use in the latter part of 2025, which is, I think, when we started to be seeing them in things like Wedinos submissions and seizures at border force. We probably won't be seeing until sort of mid-2026, which is a frustrating component of the slowness of this, but unfortunately it's the mechanism we've got at the moment.
Yeah. Okay. I have another question for you, Caroline. This is about the King's report regarding ketamine-related deaths. Asking, was it accurate in its framing of ketamine harms? And will the government reclassify ketamine, do you think?
So I do sit on the advisory council for the misuse of drugs, but I really have to stress that all views are my own and are not representative of the council at all. So the that death report, that case series with the deaths following illicit ketamine use. And what we found was that ketamine is being increasingly used in a polydrug scenario, and more and the deaths which are happening more frequently in dependent users of other substances, not just ketamine, rather than in a recreational setting. So that data was originally actually analysed for the ACMD report. That's why we did it, and we turned it into a paper. And so, but I must stress that that is the deaths due to ketamine as opposed to use, and not everybody that dies following ketamine use, that uses ketamine dies. So there is a difference in the demographic there. I'm not saying that people aren't recreationally using ketamine, it's just the deaths that are happening are more often happening in a dependent setting. In terms of will ketamine be reclassified, I don't actually know. I can't tell you that answer, because the AECMD, I've very much learned that the A is for advisory. And so we can advise government on what we think, but they won't necessarily take it. But I've actually, I've been working on this report, chatting to the other members about things, and I actually am increasingly thinking that the class of ketamine doesn't really matter if it's class A or class B. I think what will matter more in terms of preventing harms and deaths is actually the other things that the ACMD always recommends in their reports, which is things like education. So informing people of the harms of ketamine use and how recreational use can transition to dependent use, improving treatment services for ketamine dependency, and all those harm reduction initiatives. And I think that we should be talking more about the palpable things that can reduce drug harms rather than just this class system, which I personally don't think it's going to have much difference, which is why I don't think the class really matters. A lot of people who deal ketamine also deal other class A substances, so is it really going to change prosecutions that much? A lot of people who use ketamine also use other class A substances as well, both in the dependent and the recreational setting. One of the popular things in the recreational setting with ketamine at the moment, you might have heard of, is pink cocaine, or 2C, which doesn't actually tend to have any cocaine in it at all, but is rather a ketamine MDMA or ecstasy mix. And MDMA is a class A substance, so I don't think it will mean it will be policed and prosecuted much differently as it is now. So yeah, we should be focusing on the other things. Anyway, sorry, that's not really on this, but yes.
No, thank you. There's another question about toxicology perspectives. How useful is it for substance use services to complete urine drug screens for nitazines and lab testings, given that there are so many different types and more constantly emerging? Is specific testing useful?
So from this regard, anonymous attendee, I suppose if you started typing things, it might not tell us. I'm assuming that this is also substance use services grant. So I was going to say that we have some emerging evidence from overdose cases to suggest that the time it takes for a nitazene to get into the urine, it probably doesn't get there in a lot of cases if someone has fatally overdosed, but in a substance, someone that's engaging with substance use services, they haven't died. So I actually think the reverse is true here. I don't actually know if it's useful for someone to know which nitazene specifically it is that they've taken a lot of the time. All of these nitazenes are incredibly potent opioids, and you're sort of going from extremely strong to ridiculously extremely strong in terms of how potent they are, and I think the risks that would go along with using them. So, to go from the scale of extremely risky to even more risky than extreme, I think you're going to be giving the same harm reduction advice. So I think it doesn't actually matter which one is there. It's just that the fact that it is there and it is being used is enough to sort of trigger that additional harm reduction advice.
Okay, thank you. Another question on ONS processes. Do they examine cause of death fields for all deaths, or only those concluded by a coroner as drug related?
all deaths. So this is why on the ONS report, it will say deaths due to drug poisoning or something, is the phraseology that they use. They don't say drug-related deaths, and that's because somebody who has a conclusion of accident, misadventure, or suicide, or open or a narrative verdict might have involved a drug overdose scenario, but not a drug-related death given. So, for example, somebody might have died by suicide due to taking an overdose of nitazene, let's say. So that will still be coded as a drug poisoning death by ONS, sorry.
Okay. Again, that goes back to what Derek was talking about the whole context being of importance. Stefano? Stefano. Are drug death records estimated consumption rates of different drugs and legislative interventions analysed in continuous manner? It would be useful to understand what are the broader causes in changes of death rates.
I mean, that's what I'm trying to do, Stefano. But I'm a one-woman band with a small team of PhD students. There are some other groups that are trying to do this as well. A real problem in that, so the drug deaths records, we can get that data very easily, because if people have died and a tox analysis has been done, we can see how many deaths had drugs detected in them and deemed causative. And the legislative interventions, we have the dates that they were all introduced, but the consumption rates component is really difficult to ascertain, because we have surveys for people who use drugs to fill in, to give us an idea of how many drugs they might be taking and the different types and the frequency and the nature of the drug use and so on and so forth. But it's incredibly biased towards the people that have actually completed that survey, and a lot of people who use drugs won't complete it. And it's useful to also know the proportion of your population that isn't using drugs, and you can't use the non-responding half as the non-drug user half. So consumption rates is really difficult to ascertain and triangulate with the other two.
Thank you. And this is about toxicology reports. What determines which drugs are tested for or screened at post-mortem? And is it locally variable?
It is locally variable, and it depends upon how deep the pockets of the coroner is in several cases. So a majority of toxicology laboratories will perform what's known as the standard screen of their library, which is of many of the substances that are most commonly detected. So your cocaine, your tramadol, your general opioids will all be in there. But the standard screen does change over time. So I know that certain nitazenes are on there now, but others aren't. And that's because the toxicologists are looking at the involving nature of the drug market. So something like N-desethyl isotretinoin, for example, was being seen an awful lot in 2023. And that was introduced onto the standard drug screen for several of the toxicology labs. But when they didn't detect, there was a big flurry in sort of, I think, about June until November 2023. And they included it in their standard drug screen until summer 2024, but with no further detections. And so what they've done is they've taken it off the standard drug screen, because the market's moved on to other nitazenes, generally less potent nitazenes, which is a good thing in a way. But if the coroner wishes to request a test for that nitazene, for example, they will be able to test for it. It will just be at an additional cost for a specific novel psychoactive substances screen. And things like the synthetic cannabinoids aren't routinely tested for either. There needs to be a specific request and an additional charge for that as well.
You have to remember that the coroner's looking at what's caused the death. And while some things might be of interest, we can't do everything for everybody. So not every case that's referred to the coroner is going to have toxicology done. So that's one of the reasons there were problems with Dr. Shipman, because all people were signed off as natural causes. May have been caught sooner if there'd been even a referral to the coroner, let alone toxicology. But the coroner will look at it very carefully, and if the pathologist says, well, I can't see on examination, naked eye examination, or with histology, it must be something else going on, like a drug death, the coroner will just give approval. I automatically would say to the pathologist, if you think toxicology is important, you don't have to come to me for permission. Just get on with it. And so lots of coroners have that arrangement with their pathologists and the laboratories around what the screening is going to be for. And the history will tell you a lot and what you should be screening for. So it's just not going to be practicable or financially sensible sometimes to screen for absolutely everything. You got to target it.
Well, as with everything, money's behind things.
Yeah, I mean, in some cases of suicide by hanging, some coroners may not even trouble themselves with a full post-mortem examination, let alone toxicology, because what will that inform you about? The cause of death is, by hanging.
Yeah.
Some coroners may look for toxicology to see whether there's alcohol or drugs which may have impaired a person's rational thought, or whether the person may have taken drugs or alcohol to give them the courage to do something they wouldn't normally do. So how can you read something in? You've got to look at the evidence and where the evidence takes you ultimately. So there can be gaps in the information. So somebody who's taken to ED with a suspected paracetamol overdose, the coroner might just accept the cause of death from the clinician without going down the route of post-mortem examination and not find out about anything else that may be in the system.
Okay. That's interesting how variable the process can be.
Yeah.
Depending on the information that you have.
Yeah. Depends where the facts take you.
Yeah. But it's detective work, isn't it? To something, in many ways, and being a scientist. There's a question here about alcohol, which we haven't really touched on, but obviously alcohol's behind a lot of things. Is there a concern about increase in alcohol-related and alcohol-specific death rates, and how accurate are these findings, given that the figures have been huge for years, but not much policy change either?
A death by alcohol consumption is not automatically referable to the coroner, same as cigarette smoking. So it's a very sensitive area, because if somebody has a chronic alcohol problem, that will not find its way to the coroner usually. If they, for example, on Facebook down a bottle of gin and die from alcohol toxicity, that would be referable to the coroner, because it's an acute event. But chronic alcohol disease is not usually referable to the coroner. There is actually a short form conclusion, alcohol related, which a coroner could deploy on the evidence if the evidence justified it. But alcohol was not within the notification of death regulations to the coroner, and in fact, it's treated rightly or wrongly as a natural disease.
Well, a natural disease. Okay, that's an interesting piece of language.
Well, it's a social thing, how society has moved forward. Cigarette smoking used to be referred, but then if you look at other things that are referred, coroners, asbestos-related deaths are referred to coroners, whether that's from occupational exposure, say in the shipyard, but also you might have, from days gone by, a wife who washed her husband's overalls, who got a mesothelioma through asbestos fibres. So that, there are lots of things coroners are looking at all of the time with what comes our way. But I think we've got enough work.
Yeah, it sounds like it.
I think sort of add to what sort of Derek said there. I think that so the reason it's considered as a chronic alcohol use is considered as a natural cause of death there is not because the alcohol use is considered a natural thing to do, but rather the cause of death from chronic alcohol use is usually things like chronic liver disease. And because that is a physiological pathophysiology, that is deemed a natural cause of death in terms of what's actually caused the death to happen is the liver failure. It might have been caused by alcohol use, but what the actual underlying cause there will have been the liver failure, which is why then it doesn't get referred to the coroner.
Same with lung cancer, with cigarette smoking. And families, if a doctor was going to put chronic alcohol disease on the death certificate, would be up in arms about it because they didn't want to see it there. So you get all of these things at play. It's not down to the family member. It's what the doctor is comfortable with certifying ultimately.
Okay. Whilst we got you on coroner work, if your local coroner does not engage, aside from requesting access to the data, is there any way that you can encourage engagement?
Well, you could invite them to come and talk to the team, meet the team. You don't have a professional relationship. I would meet, the chief execs of all of the trusts, whether it's ambulance trust, health trust, mental health trust, because that's what coroners should be, in my opinion, should be doing. You don't have to forge friendships, but it gives a mutual understanding of what's going on. Meet the chief constable. So why not the drug and alcohol teams, and invite the coroner to speak, to talk, put together an event. Stroke their ego a little bit, but you've just got to charm them. They will say they're busy, so say, well, can you send your lead coroner's officer instead? Because some coroners would do that. If I couldn't turn out to an event, my lead officer would go in my place. So I had a seat at the table.
Thank you. This is going back to the data on tramadol that you presented, Caroline. Would be interesting to know whether the percentage reduction of prescriptions after 2014's new classification and the percentage reduction of deaths due to tramadol were comparable, to see if tramadol was maybe being sourced via other means.
Yeah, and that would actually be possible now for given the open prescribing data that is available through Ben Goldacre's initiative. So I shall add that one now to my MSc student potential project because that's a great idea. Thank you, anonymous attendee.
So it goes two ways, doesn't it? We all learn something. Leanne says, to my knowledge, netazines are not routinely tested for by our local coroner. Is there a call for netazine testing to become mandatory?
There is, but again, I think as Derek said, it's not always appropriate to request the netazine test. Yes, but it really is context dependent upon the death.
Yeah, there's got to be a discretion there. I can't imagine many coroners would shirk away if it was necessary. Some local authorities, you can have a difficult relationship with the local authority because it's possibly the only area within the local authority where they can't control the expenditure. And that's uncomfortable for coroners because you've got to work with your local authority. But some local authorities want best value, that's good. So they'll go down the procurement route, which I've already touched upon. But ultimately, if I want a particular laboratory to do something, I'll go ahead and instruct that laboratory. So, coroners are conscious of costs, but not driven by costs.
Okay, thank you very much. Next question. For Geraint, apparently I've skipped a question. Caroline, have you pinned down the ONS algorithms regarding language, what is included as drug misuse death?
I think this is from Geraint, isn't it? Yes, it is. I have scheduled the meeting. I have not yet had it. So yes. Sorry, I'm on that one. I'm in direct contact with Geraint on that one.
Well, thank you very much. That was an easy one to answer. And from Suzanne McGregor, could you remind us again, who is it that decides to refer a case to the coroner?
You look at the notification of death regulations, and it's usually a doctor who refers to the coroner. sometimes families may be in touch, or a funeral director might be in touch, and then the coroner will pick it up and run with it. Coroners are not going to ignore a referral. They should be looking at it, but mostly it's by a registered medical practitioner. If the deaths are known, or if the deaths are natural. If the deaths are known and it turns out to be natural, the coroner will discontinue the investigation. But if the death turns out to be unnatural, then every unnatural death requires an inquest. That's the 40,000 inquests that flow from over 500,000 deaths every year.
Okay, thank you. And just to let you know, we'll be coming to the end of the questions shortly by the looks of it. There's a question about a link for the Scottish Judicial Alcohol, Drug and Medication Related Death Reports page. If anybody's got that, they will be great if they could pop it in. I'm also going to pop into the chat a link for some feedback. It helps us formulate what we do next, etc. It would be really great if everybody could complete that. I've just put it in. It's a little MS form for everybody to complete, and yeah, that would be really helpful for us. It's there for you to click on. Comes from me, and there it is. So thank you very much for that. With regard to the recording being available, yes, it will. Drug Science make it available on their web pages, but it does take a little bit of time to process all of this. So I think that's the end of the questions. If anybody's got any other questions, please put them in now into the Q&A box. I'll just give you all a few minutes. I think we've gone through them all. If I've missed any out, please bump it up the list. But I think I've covered all the ones. But, I am only human. Oh, right. Okay. Joe Carlisle, has Mamba spice been recorded as a cause of death?
Ever?
Yeah, I
Yes.
guess so.
Yes. So, many. So we did publish a paper, gosh, quite a few years ago now, on deaths following spice use. I think that was data up until 2019. We do obviously have more data since then. What we were seeing was around about 50-ish deaths a year following spice use reported to the MP sum. So it will be more than that because we don't get all the deaths, but certainly a decent number of them. And what we saw was that all spice compounds were controlled or banned, I should say, under the Psychoactive Substances Act in 2016. And they've been sort of gradually piecemeal added to the Misuse of Drugs Act. And then there was a generic ban at some point introduced in the UK. But we were still seeing these sort of 50, 60 numbers of deaths a year. But then in summer 2021, China did a blanket ban on the skeleton structure of spice compounds, and which made illegal their manufacture and export. And we saw a drastic reduction in deaths in 2022, so the following year. And China is often cited as a major source for spice compounds. And I think we had 10 deaths reported to us in 2022, so a huge reduction. We have, however, seen in 2023 and 2024, it's gradually creeping up to the numbers that it was previously. And the reasons for this is that we think that the clandestine laboratories are moving to other countries that have less evolved drug laws, where it's not illegal to make these substances. It's not that the country has deemed it legal, it's just that it's not been made illegal to do so. And we've also seen reports of like DIY spice kits appearing. So it's a bit like a HelloFresh box where you can order online the ingredients and the basic scientific equipment needed to make these spice compounds at home, because the precursors, the ingredients to make them, are not controlled. Now, for some substances like fentanyl, you can control the precursors because there's only two real ways you can make fentanyl. So you can make fentanyl illegal and its ingredients. But with spice, there's so many different types that have so many different precursors that also have legitimate uses in other industries to make other things. You can't control all the spice precursors, which is how these kits have been made. It's legal to order them. And so yeah, spice deaths have climbed back up again. And yeah, I think that the main message from that is that if people can make money from drugs, they will always be willing to supply them. The way we can reduce drug harms is trying to reduce the demand, so providing education and treatment and so on and so forth.
And
So
that's a
it's a
tough
very
one
long
to
answer.
do, isn't it? That's a tough one to do. One final question here from Michael. Are alcohol-related deaths underreported?
You would never know.
You'd never know.
But yeah.
I think all drug-related deaths are underreported because, as Derek has said, not every death is tested. Not every death is sent to the coroner, and not every death which is sent to the coroner undergoes a full post-mortem with comprehensive toxicology. So, we're certainly missing a number of drug deaths, and the same will apply to alcohol as well.
Okay, thank you. Just you were mentioning about specific populations earlier, Derek. Is the data there available that certain groups of people are using certain or dying of certain drugs? And in terms of education, would that be able to filter into targeting the education at different sectors?
If locally your coroner works with your drug team, there may be certain types of information that's relevant, but coroners don't, for example, routinely look at ethnicity. And although it's on the new death certificate, it's got to be available from within the medical record, so you can't ask a family about their ethnicity. So there are channels to get the data, I think, if you are working collaboratively with your coroner and the drug team. I think it's really important because, for example, you would know in a particular area of the city that you may have a particular problem, and therefore the council, the local authority, will need to move in there, possibly with education, surveillance even, but it can direct where the inquiries go. And yes, again, simple things. I would go and talk to schools, universities, and anybody who had the patience to listen, just to get the word out there. And again, with talking to a school, if you mention about drugs and illicit drugs and you don't know what they're made from, unlike getting your prescription from the chemist with your information leaflet in, the look of horror on some young people's faces. And sometimes it is just about getting the word out there. And, perfectly healthy people dabbling, from all sort of income brackets and age ranges. And, coroners sadly get to see a lot of sadness in that respect.
Well, yeah, I can imagine it does take its toll, and a great deal of resilience is needed in that role. Just out of a similar vein, somebody anonymous again, they're very busy, has asked about are there any insights into gender and age trends that come out of the data?
The MOJ have age and gender trends, and that data visualization tool, I'm pretty sure, has age and gender information, but that's as far as it goes. Coroners, the Ministry of Justice are asked endlessly to put more and more information on, whether it's to do with how many PFDs a coroner's written, or gender, organ donation. That's another matter which often goes to the coroner if it's a coroner's case. So there's a lot of useful data, but it's being able to pull that data from the records, which is why, for example, all reporting to the coroner is done electronically. So that the doctor who's making the referral will fill in a standardized referral document, send the GP summary in. So gone are the days where the the death is referred to the coroner, and the coroner's team are waiting in a queue for the GP's receptionist to pick up the phone. We make them send the data in electronically, and that is then sucked into our system straight away, and we can begin work. And, you know, coroners, again, people may not know, but your coroner will be available 24/7 to deal with lots of things, weekend work, Christmas work. So their team are working every day of the year to deal with whatever may come their way. Thankfully, the pandemic, COVID, was a natural disease, but coroners got drawn into that excess death management. So, you know, there's a lot people can understand about the work of the coroner if they spoke as well to their coroner team and got them involved.
Well, thank you. There's another question popped up. Are there any body image enhancing drug deaths? I can see Carol nodding.
Yes, there are.
Yes.
They're not very common, but we do see deaths following steroid use, which come through. And then we have also previously had deaths due to things like diet pills as well.
And coroners have done PFD reports about buying these from online. And, you know, people, again, don't know what they're buying. And that can account for their death, sadly.
Yeah, well, the great unknown, isn't it? When people are buying these things, when they're unregulated. Right, well, thank you very much. I think that's all of our questions. We've had a large number of questions. Just leaves me to say thank you so much to Derek and Caroline for providing such informative accounts of their work. Yeah, death is clearly a very interesting and rich with data. So thank you for taking the time out to do this for us all today. And thank you for everybody who came along. And thank you, everybody, for attending.
Great. Thank you very much.
Thank you, Karen.
Thank you, everyone. Enjoy the budget.
Bye.